we faced in our practice. I'll be presenting the first case. So it is a 50-year-old female who were presented by vaginal bleeding in September 2022. Examination revealed a cervical mass from which a biopsy was taken, and it showed squamous cell carcinoma. The initial examination under anesthesia showed a cervical mass involving all lips of the cervix and extending to the upper vagina with right parametrial infiltration. Here it is a sagittal section of an MRI done at baseline, which showed the large cervical mass. It was around 7 × 6 centimeter and extending to the upper vagina. This is the mass, it's very huge, and also extending to the right parametrium as apparent. This is the right parametrium extension. There was no apparent rectal or bladder infiltration, but there was a large right internal iliac lymph node about 3 centimeter in size. So we started with concurrent chemoradiotherapy to 45 grays in 25 fractions to the whole pelvis, with simultaneous integrated boost to the positive lymph nodes to 55 gray in 25 fractions with weekly cisplatin. These are images of the IMRT plan that the patient received radiotherapy with. After, this is the MRI done at the last week of external beam radiotherapy, which showed that partial response and regression of the mass as well as of the lymph node. This is the lymph node. Now it's almost sub-centimetric in size. She was then referred to us for brachytherapy for her HDR brachytherapy boost. We are giving her, our protocol is to give 28 grays in 4 fractions twice weekly. So this is the images from the planning from the first fraction of brachytherapy. We were using the standard intracavitary brachytherapy using the ring and the tandem, which showing that there was under coverage at the right parametrium. So the D90 of the HRCTV was 6.1 gray, which is suboptimum. Because of the right parametrial infiltration, it's away from the ring and the tandem, so it's difficult to cover this area with enough dose without exceeding the tolerance dose of the rectum and the bladder. So in the remaining fractions, we started to use the combined intracavitary and interstitial brachytherapy using the tulip applicator. So here we are applying the intrauterine tandem plus the needles which are inserted in the cervical stromal tissue. So now you can see that the coverage is much better, which is very away from the bladder and the rectal wall, and the results were much more better. The HRCTV was reaching 7.5 gray, and we were able to reach an EQD total dose, cumulative dose of the external beam and the brachytherapy to about 84 grays. So this is the first case that we wanted to present. The second case will be presented by my colleague, Mohammed Darwish.
Good evening, dear colleagues, dear professors. I'm Mohammed Darwish, lecturer of clinical oncology in Ain Shams University. Our second case, actually, there was something tricky regarding this patient after it was referred for us for the brachytherapy. And as Professor Umush said in our recent workshop of brachytherapy in Alexandria, that as much as we have workshops and learning lectures, as much as we can learn, and we should implement and pass this information to our colleagues. This patient was 37 years old with post-coital bleeding. Her transvaginal ultrasound showed a mass at the cervix. Biopsy showed squamous cell carcinoma, grade 2, and actually it was HPV positive. This was the baseline examination under anesthesia when we first encountered the patient with a huge mass infiltrating all the cervix and all its lips with upper vaginal extension posteriorly. Her baseline MRI showed a huge 7.4 centimeter mass invading the upper vagina, invading the lower uterine segment with bilateral external iliac lymph nodes about 1 centimeter. This was the axial cuts. The patient finished her concurrent chemoradiotherapy with weekly cisplatin. We couldn't boost any lymph nodes because the lymph nodes were subcentimetric. We couldn't see it on the CT actually. This was her examination under anesthesia after finishing the concurrent chemoradiotherapy with very nice response. MRI in the 5th week revealed regression of the mass significantly, yet the uterus was slightly retroverted, and this actually gave us a problem that when she began her first brachytherapy session, actually the uterine tandem was going in the wrong position, although we chose the most obtuse angle. Yeah, and the lower uterine segment was undercovered where the arrows are actually point to. This was where the mass was infiltrating the uterine segment. HRCTV D90 was 6.3 grays, which is suboptimum. On attempt of the second brachytherapy, we actually tried to retrovert the uterus. We put a larger or a longer tandem in an opposite direction towards the rectum. Then with another finger in the rectum of the patient, we actually twisted the tandem and pushed the fundus, which we actually we felt from the rectum, and we twisted the tandem to retrovert the uterus. And actually the results was very nice. And the uterus was covered with the cervix was actually covered with the lower uterine segment and the upper vagina, and the HRCTV showed a dose of 7.4 grays. The sigmoid dose was slightly higher because the sigmoid, when we antiverted the uterus, the sigmoid fell off on the cervix. But at the end, the total HRCTV EQD2 was 84 grays, which was optimal. And we actually did a new examination for this patient after she finished brachytherapy, and we find a very, very small ulcer or very small induration of the cervix, and it was a very good response after just only 2 weeks of her brachytherapy. Thank you for your intel. Okay. In the first, as you saw in the first patient, we actually were filling the bladder with 50 to 60 cc's. Yet we found that the bladder dose was actually high, 50 to 60 cc's of saline with a 1 centimeter of contrast. Yes. This actually showed that the bladder doses were high because, as you see, the posterior wall of the bladder was sagging on the laterally from the HRCTV, so this increased the dose. Recently, we began to just put only 10 cc's after the recommendation and the advice of Professor Umesh and Dr. Hodelbouz, and this significantly decreased the bladder dose after that. Yes. Thank you. Of course.
Thank you. If we are not proud of anything else except that we maybe have been tutors for some perfect, good friends and colleagues who are doing great job. Thank you, Dr. Ed. Thank you, Dr. Christine. Thank you, my dear colleagues. Ain Shams is coming back from the dark ages to the frontier. Thank you, Dr. Omesh. You did great job. You pushed them further, like 10 years forward. So thank you so much. Thank you.
Thank you. Thank you, Dr. Khalid. Thank you, Professor Umesh. Thank you.